Manjunath T, who is the consultant critical care from Manipal Hospital, Whitefield, Bangalore, India. So he would be talking about AKI care bundles, which has recently published in critical care, and what the article has to say and what we can like take home as a message. So Dr. Manjunath, over to you.
Hi, Tapas. Good evening, all my senior colleagues, my teachers, and my friends. So, Tapas, you can see my slide?
Yes, yes.
Yeah, fine. So, yeah, I'll be talking on the AKI care bundles, how it is being used. So, in this meta-analysis, so I know the meta-analysis is the big chunk in the evidence-based intensive care medicine. To keep it as simple as possible in the next 10 to 15 minutes is very difficult. So I'll make sure I'll keep it as simple as possible. So contents of my talk. So the current practice, what actually is going on now, and next comes undesirable practice. So with also the new advances, and what is a bundle? What is its importance? So we know the most of the things as on the WAB bundle, the COTI bundle, the CRBSA bundle, and all that. So what exactly is a AK care bundle, and what all the societies actually come up with this AK care bundle, and the critical appraisal of the systematic review and the meta-analysis. So the current practice, and we all know that the major high-risk patients or patients who come to the intensive care unit and the post-op, the cardiothoracic surgery, the patients, nephrotoxic medication, the patients, and the patients with the post-renal transplant. In these patients, so we see for the risk factor, see for the urine output, the creatinine, the urine analysis, and all that. And then we do so, and we divide them into pre-renal and the renal and the post-renal, and do the generic and the treatment. With this, what we can see is the suboptimal outcomes. So where there is late recognition of the acute kidney injury and the need for the renal and the replacement and the therapy in all the patients, and further testing, it might actually need for the underlying and AK etiology, whether it's a renal disease per se with a biopsy. And with all this, so we all know the prolonged ICU stay and the hospital stay as well. So what we exactly want with this nephro intensive care and the society, so we need to come forward with newer practices, desirable practices, and something along with and what we are doing. Along with that biomarker, the panel, and there are many biomarkers which actually tells us about the pre-renal injury, the structural and the damage to the kidney. So if at all, if we start doing those parameters in our practice, we actually can detect the acute kidney injury as early as possible within 1 to 2 hours of the acute kidney injury. So in that, so we actually can stratify on the low risk and high risk patients, and with that, and we should optimize and personalize the treatment for mainly high risk patients. And our desirable outcome should be a reduction in the acute kidney injury occurrence, and reduction in the need for the dialysis, and the prevention of the injury progression, and the shorter ICU stay. So with all this, the bundles, so we all know it should be a simple, on the 3 to 5 elements. So we all know with the WAB bundle, the COTI bundle, and the CRBSI. So it should be same with this as well, with the AKI care bundle. But these interventions should be based on the level 1 evidence or accepted and should be well established. Bundle interventions, it always implement the change in our practice and also improve the culture of the patient safety by promoting the teamwork. And AKI care bundle has been brought out by the KDIGO, the Stop AKI bundle, and the Save the Kidney Foundation, and also AKI bundle by NCPOD. So the and KDIGO bundle, so where they have mainly taken discontinue all the nephrotoxic agents and ensure the volume status and the perfusion, the pressure, consider the functional and the hemodynamic monitoring, and monitoring the serum creatinine and urine output, and avoid hyperglycemia, and consider the alternatives to the radio contrast procedures. These are called as an AKI care bundle according to the KDIGO. if you see for like a stop AKI, the stop AKI is something so where they have gone way behind that, and they have seen the patients with the sepsis and hypoperfusion and the patients with the toxic drugs and the obstruction. It is same like pre-renal and renal and the post-renal, and also they have seen and the something called and the hidden renal diseases like HUS and the TTP or any intrarenal diseases. So with all this, so we'll come to our meta-analysis, improvement of the composite, the kidney outcomes by AKI care bundles. So in this, the main introduction of this analysis is, and they have seen the patients with the in the intensive care unit, so where the 50% of the incidence of the acute kidney injury is seen with the septic shock patients, and also 3 to 39% of the patients have undergone the post major cardiac surgery patients, and also 64% of the incidence was with major non-cardiac surgery. And in all these patients, and we make sure that if at all, if we implement AKI care bundle, the and also with the avoidance of the further insult to the kidney to prevent the progression to the CKD and unfavorable outcomes can be prevented. So with the biomarkers, apart from the AKI care bundle in this study, and they also have seen with the usage of the biomarkers how exactly it will prevent acute kidney injury and the need of the renal and replacement therapy, and also mortality of all the patients in intensive care unit. So with this biomarkers, so we all know, and the KDIGO definition still tells about the serum creatinine and urine output, but these are actually relatively late markers. So if at all, if I have to take and the new biomarkers in this, and there are many with glomerular function and the structural damage, the most important thing is and the cell cycle arrest markers, so which actually get detected in the urine within 1 to 2 hours of injury. So, and these two are the mainly FDA approved biomarkers of the acute kidney injury. It is tissue inhibitor metalloproteinase 2 and insulin growth factor binding protein 7. So objective of this meta-analysis was compare the effectiveness of acute kidney injury, the care bundles with and without the biomarker. So as we all know, I already showed about AKI care bundle. It is the same bundle here, optimization of the hemodynamics and the fluid status, prevention of the insult, and avoidance of hyperglycemia. So the materials and methods for any meta-analysis, whatever is standards, it is being used here. The PRISMA guidelines and the protocol was actually registered with the international body, and the comprehensive search was done in the PubMed, MBES, and the Cochrane library initially, and they got around 7,000 studies, and with that, and they have done the screening, and they took up their eligibility and all that, and finally they came down to on the randomized control trials of around 5, and also a non-randomized controls of around 8. Totally around 13 studies is being used. And criteria, these are the inclusion and exclusion criteria. Mainly the excluded the patients with the CKD who are actually dialysis dependents, and patients with pregnancy, and also and lactating patients. So if at all, if you see at all the characteristics of the study, so nearly around, and the 5 studies are actually on the randomized control study. So in that, I think around 70% of the studies have used KDIGO care bundle, and the few have used actually the goal directed and the therapy of the sepsis, and few have actually used the Save the Kidney Foundation. So it is not uniformly seen in all the studies, but majority of them have used actually KDIGO care bundle. So, and the second thing is the biomarker usage for the to see for the incidence of acute kidney injury. The nearly 80% of the studies have used urinary TAMP2 and the insulin growth factor, but few have actually and used NGAL as well. And The third most important thing is all the studies have seen for the outcome to see for the incidence of acute kidney injury stepping into the stage 2 or 3. So these are the other non-RCTs, and study selection and data extraction. So they had mainly two investigators. If at all, if they had any disagreement, and they had a third investigator as well. And the outcomes, what they have seen mainly is and investigate the effectiveness of AKI care bundle. So with respect to the moderate to severe AKI, as per the KDIGO stage 2 and 3, and receipt of the renal replacement therapy, in the sense the patients who actually required the dialysis or mortality of the patients in ICU. And the second thing is, along with the AKI care bundles, they also have seen the studies which actually use the biomarker and the statistical analysis. So we know it's most updated on the software with under Raymond, and also and these studies had some amount of diverse in the methodology. So they've used forest plot and also the random effect analysis, and to see for the risk of the bias and the ROB 2.0, and also for the non-RCTs Newcastle. The forest plot, if we take the major adverse the kidney events, it means the patients who are stepping into acute kidney injury of on the stage of like a 2 or 3, or on the requirement of on the renal replacement therapy or ICU mortality. If you see here, the incidence of the like MAKE with the patients with care bundle with biomarker and without biomarker. So if at all, if you look at the quality of the studies and use, heterogeneity is actually around 0%. So it means the quality of the studies with biomarker, with care bundle, which is actually good. And if you see at the final result, the diamond mark is actually towards on left side. It means it actually favors the care bundle with biomarker. If at all, if you see with the other one, in the sense the care bundle without the biomarker, it still shows some amount of the benefit. And if at all, if you see the combined effect, so if you can see the combined effect here, the MAKE on the incidence with biomarker or without biomarker, it has shown benefit with care bundle and biomarker. Yeah, coming to the incidence of the acute kidney injury, in the sense the patients who are stepping into the stage 2 or 3 or in the first 72 hours. With this, if at all, if you take here, the heterogeneity is actually the 0%, and still it has shown the benefit, the care bundle. So with the biomarker, if we take the without the biomarker, so here I square is actually like 59%. It means the heterogeneity is, it steps into moderate heterogeneity. So, and what I felt, looking at all these three studies, the Cole et al., the 2016 one has got odds ratio of 1.33. In this study, especially, they have targeted the map of around 60 to 65. So with this and the lower map, the probably the generalizing the map for all the patients, it might actually increase the incidence of acute kidney injury, which actually affected the overall score here. The still it is the odds ratio, the confidence interval has come up to around 0.99. So with this, and we can say the incidence of the major adverse kidney events, the composite outcome and the acute kidney injury with the usage of the care bundle and the biomarker, it has shown some benefit. And if I go to the next one with the requirement of the renal replacement and therapy, it is the same. With all the biomarker, it is actually the quality of the study is good, but still it has actually the diamond has actually crossed the 1. So it means it is not so favorable with the requirement of the renal replacement therapy. And so without the biomarker, it is still the heterogeneity is actually too high, and it has crossed the midline, and comes the combined effect, it has shown some benefit. So with all cause mortality, so if at all, if I see here, it has not shown much of the benefit. So with combining the care bundle with the biomarker, So if I see with RCTs, so in last 4 slides, so we saw RCTs and non-RCTs, the care bundle, so with biomarker and without biomarker in that, and we saw the incidence of the MAKE and also incidence of the acute kidney injury was actually reduced. But if you see with only under randomized control trial, so with respect to the AKA care bundle, so on the first one, the figure A, the table A, is actually tells with all the 5 RCTs, it has shown the benefit, which is actually away from the midline. It actually favors the care bundle, and comes with the B, where incidence of acute kidney injury is being seen. The heterogeneity is hardly around under 7%, which actually fits into the low group, and still we can see the, and it favors the care bundle. So here they have not seen any biomarker. So with respect to the usage of the only AKA care bundle, it has shown the benefit, and with respect to the composite outcome, and also with the incidence of the acute kidney injury. And if I see with the other RCTs and with respect to the renal, the replacement therapy with mortality. So here, if at all, if I see the heterogeneity is actually around under 0%, but still it has not so favor with respect to the care bundle. So, and I feel it is all because of these two on the same study with March 2017, with a confidence interval of the 1.4 and the odds ratio of the 1.46. So if at all, if I can say, they would have done, they could have removed this on the RCT and could have got the unfavorable outcomes, but it actually goes in favor of on the selection bias. So where they actually take out all the negative studies, but they have not done that. So I think because of that, it has not shown much of the benefit, and with respect to the renal replacement therapy and the mortality. Coming to the summary of and the risk of the bias. So here, I think all the 4 and the randomized control trials has got the issue with the blinding of the participants. So because it's a treatment algorithm, so it was actually difficult for them to do the blinding. But for us, it actually amounts for a moderate amount of bias, and with all the 5 studies. And to avoid the publication bias, if at all, if I run a funnel plot here, all these studies, it comes under the funnel plot. So to avoid the publication bias. Discussion. So with all this, so we can so major adverse kidney events. So though they have used in few of the studies with biomarkers, and we might have to use that along with the acute kidney injury care bundles, but in few of the patients with on the low risk, in the sense, the patients who had the TI-IMP2 and less than 0.3, and if the patients who had with a 0.3 to 2 or more than 2, they are actually divided among them into low risk, moderate risk, and high risk. In high risk patients, and they have actually more invasive hemodynamic monitoring was used with SVO2. So with this treatment algorithm, so to improve the outcomes, and they have done so much that the incidence of AKI and the requirement of dialysis should be reduced, but it cannot be extrapolated to all the studies. Few of the studies have done this, and the limitation of this study is the main, and the limitation of the studies generalizability, and they've included all kind of patients, intensive care unit, emergency patient, the post cardiac surgery patients, and the non-ICU patients. So it's very difficult to tell that which patients actually got benefited here, and the studies were actually heterogeneous in design, and explored different outcomes. So if at all, if you remember with the forest plot, when they did the pool studies, there was actually mortality reduction was there. When they did a separated data without and with biomarker, so we saw the moderate heterogeneity. And with all this, it's actually difficult to tell the which component of the AKI care bundle had a bigger impact in all these in the studies. So, and the other important limitation is lack of the blinding among so nearly around four and the randomized control trials, which actually potentially impacted some of the outcomes, mainly the timing of the renal replacement therapy. So, with all this and with this meta-analysis, the existing literature which has confirmed the beneficial effect of the AKI care bundles on the composite outcomes of the acute kidney injury. So, and we might have to consider using this and also on the role of the new biomarker into our practice. So the conclusion, the strongly suggest a significant and a trend towards a reduced risk of the MAKE and also better outcomes when we implement the biomarkers into our practice, and also further studies are actually required to see the to explore the impact of individual components of the AKI care bundles. And my comments on this analysis, there is a presence of heterogeneity, heterogeneity in a few of the on the studies, but they have not actually commented the why there was under so much of heterogeneity. And if at all, if there is like a moderate heterogeneity, and we might have to do the sensitivity uh, analysis, but there is no comment of the sensitivity analysis in this study. And the AKI care bundle, whatever we have in the KDGO, it is basis on the expert opinion and rather than on the robust evidence. And the few of the and the studies have used NGOL. It is not uniformity in the biomarker and for all the studies. Do I implement in my ICU practice? Yes, it's mainly for the high risk group, and I should incorporate the AKI care bundle as any other bundle for the routine ICU rounds, and I should start using the more often the kidney injury biomarkers. Thank you.
Thank you, Dr. Manjunath, for highlighting this important care bundle in our day-to-day clinical practice. So now this forum is open for the discussion from the panel. The panelists, any comments? Anything that you want to share and add on in the existing literature that Dr. Manjunath has shared in detail? Dr. Valentine?
No, I think that's excellent. I agree with him. I think that care bundles make a difference and that it's the bias in the studies which in some situation fail to show that difference. So yeah, I agree with the results of whatever he presented. Nothing to add.
Dr. Ranajit?
Yeah, very well presented, Manju. I congratulate you for the studies of critically explaining the studies. Actually, if you remember, Lobo, we both of us present during the annual conference of ISCC this time with Merlin Misterman. And she has given that 2020 paper where she has, along with the KDIGO guidelines, she has incorporated the biomarkers.
I remember that.
1S, 1A, and 1B, 2B. You must be remembering. I asked Merlin, it's a fantastic one that you have done. But exactly which biomarker you are talking about?
Yeah.
She couldn't answer because even we don't know which biomarker is the best one to be at this present moment to be used. For example, TIMP2 and IGFBP7, the multiplication factor that Manju showed, the urinary level of 0.32 and more than 2, that's what she is saying. It's a good one. It's a cell cycle arrest marker, but it has to be validated in most of the cases. Without validation, we just can't take this biomarker because NGAL is in the use for the last 1 decade. We are using NGAL, both serum and urinary. Serum is more used because we're getting easily in India, the cartridges. But again, I don't know because in sepsis patients, sometimes NGAL levels are very high inadvertently. So there are many co-factors, these confounding factors, which affects these biomarkers. It is still time will tell exactly which biomarker to be used in detection of AKI more promptly, what I feel. Otherwise, it's a very excellent presentation.
Thank you.
Thank you.
Dr. Sanjay, Dr. Makunda, anyone who wants to comment upon something related to this? Dr. Flavio? Or else we'll be going to the
I
next.
will just say that the bundle, of course, in high risk groups is certainly a good idea. Now, going back to the question of incorporation of biomarkers, I mean, of course, we have been talking about biomarkers for 20 some years, and yet it has not made that stride where it makes a difference to the clinical management. The superiority over creatinine to either prevent an acute kidney injury occurrence or have an indication to dialyze earlier or later. So that part has still not been established despite all the efforts by many qualified personnel over the years. So that has been my take on this whole situation. And we've been talking about biomarkers for a long time. Hopefully there's something else that will come in the near future, but definitely bundles seems to be the way to go.
I agree with you, Sanjay.
So just to add, maybe patient education should be also part of the AKI care bundles, because we are only talking about the treatment part or the early diagnosis, but we need to also like educate patients, families about the risk factors, the importance of follow-up also. So that should be also one of the key factor that would be reducing the impact of this AKI in the comprehensive healthcare, the resources and like how we are providing the service to the patients. Yeah. So with this, we come to the last, the journal club discussion, and that would be by Dr. Srivasta. He is the consultant intensive care at Apollo Adlux Hospital, Kochi, India. So he would be discussing about a very important recent article published in Enigen. Yeah. So over to you, Dr. Srivasta. In the meantime, there are almost 44 questions in the chat box. So I would be answering these questions later on because of paucity of time. So we would be going to the last discussion by the our next faculty, Dr. Srivasta. just 30 seconds. There is some internet problem with Dr. Srivasta. He's just doing the needful.
Thank you, sir. Hi, good evening, everyone. I think it's been the last talk of the day, and then there was some technical glitch. I hope I'm audible to everyone, right? Okay. So this is the last talk of the day, and I know everyone is tired, and then I'm standing between you and the sleep. But trust me, I'm definitely going to wake you all up and then cheer up with my journal club. So imagine like it's like a post-credit scene. I know all of you have been riding high wave on a knowledge of third nephrocritical care update. But without much delay, let's get into our topic. So today's journal clip, what I'm trying to do is about the Convince trial. So it's a recent trial which came up in the NEGM. But before going into the depth of the trial, I would like to add some background to that. So the background is that uh, the global prevalence of kidney failure is estimated to be around 0.1% of the general population. And if you look at that, it's roughly affecting around 10 million adults worldwide. And out of the 10 million, about 4 million require kidney replacement therapy. And the burden is supposed to be increasing in the next coming future, near future, due to rising incidence of risk factors like diabetes, hypertension, sepsis, obesity, aging, and everything. And the standard of care for end-stage kidney patients globally is hemodialysis. However, hemodialysis patients face high risk of cardiovascular events, infections, frequent hospitalizations because of pulmonary edema, and reduced quality of life. And if you look at the survival of these patients living with end-stage renal disease on dialysis, it's quite poor. it's quite poor. And if you look at the epidemiology of hemodialysis outcomes, the 5-year survival rate stands at about 40% from the US RDS data. And this survival is many years less than the general population. If you take roughly around 40-year-old person, it's whooping 40 years shorter lifespan for someone in their 40s. And not so insignificant shortening for a person who is around 70 years, who is about 70 years. It's roughly around 10 years. But again, it's a significant burden which is putting on the general population. And if you look at the mortality, when comparing with the big cancer, big C, dialysis fares very poorly, and survival is not even better for dialysis compared with the breast cancer, colorectal cancer, or prostate cancer. And only lung cancer or pancreatic cancer have a shorter survival than dialysis. So those are the only two big Cs which have the worst mortality compared to dialysis. And this is not because of the lack of trying, or it's not because of not trying more dialysis, especially in terms of the adequacy, time, frequency, and they have been trying even polar dialysate or high flux filters and all these things. But most of these things has failed to demonstrate an improvement in survival. And there is been a search for this magic pill. And if you look and if you're moving forward with this, so, and if you want to go beyond high flux filters and cold dialysate and the frequency, time, there has been a rising question whether hemodiafiltration could be the answer, whether it is a magic pill which will tell you the truth. So that comes to my topic, hemodiafiltration versus high flux hemodialysis. And is there still a need? Is there a need for convincing evidence, or we're all convinced with this trial? So let's get into it and then let's see what the evidence says. So before going into that further, so we'll try to look into the rationale of the publisher's thing. So the first rationale is in hemodiafiltration, diffusion and convection are both are combined as the driving forces for the uremic toxin removal. And hemodiafiltration with online production of substitution fluid offers a modality to allow day-to-day usage of hemodiafiltration. And substitution fluid is the most often delivered in the post-dilution mode. And there are 4 major RCTs which address this question, whether online hemodiafiltration offers any clinical benefit. But there was no any definitive answer which was produced. However, if you look at the individual participant meta-analysis, it provided the direction future research. And this is the data. And if you look at that, what it says is when online hemodiafiltration is adjusted to the body surface area, and if you look at the convective volumes, when the convective volumes went up more than 23 liters per session, there was a significant reduction in all-cause mortality. There was significant reduction in cardiovascular mortality, infection-related, and as well as sudden death. But there were certain problems with this meta-analysis. One was the inherent bias associated with all those studies, and none of these studies had the true intention to treat spirit. And if you want to know further about this in-depth analysis, you can go into the link by Green et al., which was published in 2005. You can get to know more about the dosing targeting biases from the post hoc analysis, which has been done in this way. And another rationale of the author is, so if there is a suggestion that online hemodiafiltration in post-dilution mode may offer clinical benefit, and if there is a definitive proof which is lacking, then we should go ahead and do a trial which shows the truth. So though there have been trials in hemodiafiltration, if you look at the data, most of them comes from the Europe, where the hemodiafiltration use is very much widespread. And these trials had several limitations. And that led the nephrology and as well as intensive care community divided into believers and non-believers. And that reflects a wide landscape where the acceptance of therapy shows a greater geographical variability. And this has left the nephrology community unconvinced, and even some intensivists as well, including me. So indicating that there is a need for ongoing debate about the efficacy and as well as applicability of this treatment method across different geographic regions. And coming to my core study, which I thought of discussing, if you look at the study's focus, it's predominantly on comparing the effects of high-dose hemodiafiltration versus the standard high-flux hemodialysis on mortality in kidney failure patients. And how did they design the study? They designed the study to be pragmatic, as much as possible practical, and they made it open label. As we know, all the interventions, it can't be closed label, so it's obviously open label. But again, one of the drawbacks of this thing is it's a Eurocentric trial. And the good thing is they include almost 61 centers from 8 different countries, including both academic and non-academic centers. And the randomization was in 1:1 ratio. And the primary objective of this study, convinced study, was to compare hemodiafiltration when delivered consistently in high dose with high flux hemodialysis treatment, whether it led to reduction in all-cause mortality. So that was the primary objective. And there was few other secondary objectives as well, like comparing the treatment in terms of cause-specific morbidity and mortality, and assessing the patient-related outcomes to capture the patient's perspective and compare between the treatments. So that is what makes me much more interested in this study. And also to assess the cost effectiveness of high dose hemofiltration. As we know, it comes with a cost. It's not that cheaper. So if you look at the participants, they included somewhere around roughly around 1,400 patients with kidney failure. And the inclusion criteria was the patients who were aged more than 18 years and been diagnosed with end-stage kidney disease, and they should have hemodialysis for at least 3 months. And they should likely to be able to achieve at least high dose hemodiafiltration. That means more than 23 liters in post-dilution mode. So that's what showed significant benefit in the meta-analysis. And all of them should be willing to have a dialysis session with a duration of at least more than 4 hours, 3 times a week. So it's a stringent criteria if you look into that. And the patient population is also very much younger and healthier. And what all patients they included? It was an extensive exclusion criteria, and several participants non-compliance to the dialysis procedure and accompanying prescriptions, especially the frequency and duration of dialysis, they're not willing, they were excluded out of it. And if the life expectancy is less than 3 months, again, they were excluded. And if the hemodiafiltration treatment, if it is less than 90 days before the screening, again, they were also excluded. And if the anticipated living donor kidney transplantation was supposed to be happening in the last 6 months after screening, again, they were also excluded. It's a long list of exclusion criteria. And if you look at the evidence for any of the medical conditions that may interfere with the planned treatment, which will affect the participant compliance or place the participant at high risk for treatment-related complications, again, they were excluded. And if they're not available for more than 3 months for the study visits, again, those are excluded. This is an extensive list of exclusion criteria. And what did they look at, and what was their primary outcome? The primary outcome was all-cause mortality. It was an inclusive all-cause mortality. And there were several secondary outcomes as well, like cause-specific mortality, what was the recurrent hospitalization, and was there any cause with respect to any infection-related things, and what is the kidney transplantation. And they even looked at the cardiovascular events, like death from the cardiovascular causes, non-fatal myocardial infarction, strokes, and therapeutic coronary procedures which required bypass grafting, PTCS, stenting. That's what we encounter routine in day-to-day life of our chronically ill kidney patients on dialysis. And if you look at the baseline characteristics, it was more or less similar with respect to age and the history of cardiovascular disease, diabetes, but the population of diabetes was significantly lesser, and the history of cardiovascular disease was also lesser in the group. And the dialysis vintage or median duration was roughly around 30 months and 35 months between hemodiafiltration and hemodialysis. And the most important thing, if you look at that, vascular access, and most of them had, 80% of them had an access through the native fistula. And that is how they were able to achieve high dose of hemodiafiltration. And previous kidney transplantation was again lesser. And so that is the reason why you can't generalize this thing for a patient who had already had a transplant and had a secondary graft failure. And if you look at the convective volumes across the visit for a hemodialysis group, they persistently able to maintain more than 24 to 25 liters per session in almost all during the duration of that median dialysis duration of 36 months. And average levels during the stay, as you can see, it's roughly around 23 plus or minus 2 liters per session. And even if you look at the variation in KT by V, we know higher the KT by V, the better the efficacy of the dialysis. And if you look at that, again, there was a good separation between the hemodiafiltration and high flux hemodialysis. And though there was an average levels between the trial and the mean difference over the time between the treatment arms obtained through the linear mixed models, all the statistical things was there, but still they had been able to achieve the decent separation. And if you look at the results, out of this 1360 patients, the randomized 683 patients to the high dose hemodiafiltration and 677 patients to the hemodialysis. And if you look at their primary outcome, the primary outcome of death from all cause occurred in 118%. That means roughly around 17.3% in the hemodiafiltration arm and 148 patients in the high flux hemodialysis arm. So if you look at that, there was significant 23% reduction in mortality in patients who underwent high dose hemodiafiltration. And you can see the Kaplan-Meier curves, which has a wide separation at the end of 30 months. And even the more interesting thing was the exploratory subgroup analysis. If you look at that, the younger patients, especially the patients who had less than 50 years, they had a significant benefit of high dose hemofiltration. So that tells us that this is a good modality if the patients had chronic renal disease diagnosed at their younger self. So this is much more going to be helpful to them. And even if you look at the pre-existing cardiovascular diseases, the people who did not had any cardiovascular events, they had a significant benefit from the high dose hemodiafiltration. And as well as patients who did not have dialysis, again fared better. So that's what I have circled around with red. That's what you can see over there. So high dose hemodiafiltration is especially helpful in patients with lesser age group who are more younger than 50 years and who don't have any pre-existing cardiovascular diseases and who don't have any pre-existing diabetes. And if you look at the secondary outcomes, and that was quite interesting as well. If you look at their cardiovascular outcomes, again, the death was lesser in the patients who did not have cardiovascular disease previous in the high dose hemodiafiltration group. And when it comes to infection related one, again, patients who had COVID had a significant reduction, but that was not seen when you excluded the COVID. So the mortality benefit was not seen when you excluded the COVID. That was one important thing in the secondary outcomes. And the perspective, what I get from this very convinced trial is that it offers a new insight to me that we need to be very much stringent, especially when choosing hemodiafiltration with respect to patient selections. And high volume online hemodiafiltration can be delivered over a prolonged period of time, which they did for over more than 4 hours of time. And all-cause mortality, as I told you, that was the primary outcome. It has a considerable beneficial effect of around 23%. So that's commendable. And even if you look at the selected patients, most of them had good access. And as I told you, that was the most likely reason why they could achieve higher dose of hemodiafiltration. And if you look at the cost specific, which I told secondary outcomes and as well as subgroup analysis, you should interpret them with caution because they are not powered to show any statistical benefit. And again, the planned power was not attained by the study. And there were no safety concerns as well, especially with respect to hygiene and infection control measures. So what this gives to me is that it's a step in the ladder to make dialysis better. So that's what perspective what I get from it. But however, there are certain strengths and limitations which we need to discuss. So the strength of the study was well-designed trial with a large sample size, but however, they could not attain the targeted sample size because of the COVID restrictions. And it was a very much practical trial, pragmatic trial. And there was an independent academic committee that reviewed the trial. So that gives again strength to that. And there was a high recruitment. Almost 96.7% of the patients who approached were agreed to participate in this trial. So, and even dropout rate was less than 5%. So that's a quite commendable job what the authors did. And even if you look at the adherence to the protocol, what they have said, it was almost 92%. As I showed you in my previous slide, most of them were able to adhere to the protocol, and 23 liters, more than 23 liters were achievable in convective volumes as per the per protocol analysis. This was the major strength. But however, if you look at the generalizability, if you look at the limitations, generalizability is a predominant issue. Why? Because this trial was predominantly done in the European nations. Again, we know hemodiafiltration is predominantly done in the European nations. So again, we don't know how much we can apply it to the Asian countries and other ethnic different groups. And also there was no ethnic data available as well. So that makes the generalizability less likely. And also there were difficulties in achieving the level of convective volumes in the general hemodialysis population. And one of the more important out of what I would have expected is the lack of data on the clearance of middle molecules, especially beta-2. As we know, it is one of the important molecule, and it would have given much more better impact on the outcomes and then interpretation of the data. And if you look at the whole of the data, there was lack of data on the residual urine output, and it was missing in almost 90% of the patients. And again, we all know the limitations of an open label design. That was one of the significant thing. And another important concern, what I noticed in this trial was not reporting all the adverse events. Specifically, why this is important, because we all know that RRT does have some amount of trauma, and that increases the mortality as well. So we don't know how much significant of the adverse effect contributed to the mortality and how it changed the things. So that is one thing which I was interested into this thing. So coming to the conclusion of it, so online hemodiafiltration, when delivered in a dose of more than 23 liters of convective volume per session in a post-dilation mode, resulted in a lower risk of death as compared to the standard high flux hemodialysis. So that is what the take home message is. But I would be very cautious in taking that, because this finding allows for a wider spread acceptance of this treatment modality. But we need to be cautious and we need to select the patient population very stringently rather than applying as a blanket therapy. So that is what the conclusion is about. And I would open the discussion for all these things, because we need to have a comparative analysis with other trials, previous trials, and how this can be applied to the ICU population is another question which comes up in my mind. And what is the future direction this gives? And do we need another further additional studies are needed to understand the benefits and limitation of hemodialysis? All those things are still remain unanswered with respect to the ICU population. Thank you. Thank you, sir.
So thank you, Dr. Srivasta, for this elaborative discussion on this very important article published recently. So as we are running short of time, so one or two quick comments from the panelists about this study as well as the presentation.
So thank you, Srivasta. I'm Dr. Mukunda Kafli. I am speaking from Kathmandu. So thanks is to Dr. Tapas for organizing all this great program. It is such a privilege for me. We are still in a yet to start the critical care nephrology in our part of the world. So it is so overwhelming that I am amongst you, and there were so good talks by Dr. Kiran, Dr. Srinivasa, and Dr. Valentin Lobo is a machine man, that what I know. So thank you very much, sir. It was so great talk that you took us through, and it gives me so much pleasure to be throughout this program and learn so many new things. Hopeful that we will do some progress in this field in our country also. I would like to thank Tapas for having me here. Thank you very much.
Thank you, sir, for those encouraging words. Yeah.
Tapas, can I make a few
Yeah,
comments
please.
about the last paper?
Please, sir. Please, sir.
Yeah. So CONVINCE is a trial which comes from the chronic kidney disease population. Its results are not at all in this format applicable to the AKI intensive care patient. Having said that, 23 liters over 4 hours is a huge volume of replacement fluid to deliver. It means 100 ml per minute of replacement fluid or substitution fluid, since that is the terminology on the Fresenius HDF machines that is used. That means to get a filtration fraction of less than 25%, your blood flow has to be...
33%. It went up to 33%.
Yeah. So to your blood flow will have to be 400 ml per minute. Now, the pooled analysis that he referred to, which is Blankenstein's paper in the NDT of the earlier 3 trials, they created a nomogram that as per body surface area, what should you deliver? So on that nomogram, you can put in the height and weight of a patient. So I put into that nomogram what happens to a 60 kilo Indian with 165 centimeter height, and it comes to 22 liters. So it's still a large amount. The second part was the no safety concerns. Before the contrast study was done in 2011 in this population, they looked at, in the Netherlands, 680 readings of the water. So you have to have ultra pure water, which has a bacterial count of less than 0.1 colony forming units per ml and less than 0.03 endotoxin units. Now, in our center, 34 dialysis units send their water. And in 2022, we analyzed 249 water samples. In 2023, we analyzed 231 water samples. About 50% met the European standard of less than 0.25. The rest were more than 0.25 endotoxin units. So such centers cannot even think of doing hemodiafiltration because you will be giving your patient an endotoxin load. And this is at 0.25, not 0.03. Only 25 samples came to us in 2023 for 0.03 endotoxin unit detection, and half of those were from our own center. To deliver this type of water treat of UF of online hemodiafiltration, it has been used in the SLED mode. So the machines are available, but we would need to monitor our water extremely carefully in order to deliver this type of a treatment, because you are putting the fluid without the safeguard of the dialyzer straight into the patient's bloodstream. So the water has to have that 0.03 less than 0.03 endotoxin units. Otherwise, you will be giving the patient a load of endotoxin. And that is not the status. In Pune, we have over 100 dialysis units. Only 34 send their water to us for water treatment for testing. The rest may not be testing water. I don't know what happens in cities across India. We need to look into that first. There is a meta-analysis on using online hemodiafiltration SLED-F mode in acute care, and that is published in 2021 Critical Care, I think. It's a Chinese author, and they showed that there was a 31% mortality reduction in this situation also. So it may have applicability, but we need that water purity standard. Finally, in 2024, we need to look at what we are doing to generate these volumes. To do one normal hemodialysis, we use 120 liters of water, which we get through reverse osmosis from 250 liters of feed water. When we go to online hemodiafiltration with ultra pure water, we will be starting with 600 liters of feed water to do one such treatment. So can we afford the environmental cost at this stage? These are questions for us to answer in the future. Thank you.
But if you see, Lobo, and the blood flow they have gone up to 400 ml, and the filtration fraction is more than around 33% they have achieved. I don't know what
so
they are doing with
I
this.
can answer that bit about the filtration fraction. Most of modern machines, whether you are looking at Fresenius with the auto subflow software, Gambro with ultra control, B Brown, Nipro, all of these have a auto sub delivery system where the machine monitors the transmembrane pressure and optimizes the substitution flow rate without compromising the filter's integrity and without really worrying about filtration fraction. So if you turn on the auto subflow on your 5008 machine, then with a flow of 350, we managed to deliver about 22 liters in a 4-hour session. So when you go to SLED, you don't even need that much. We ended up by delivering 132 liters over 24 hours in SLED-F mode. So you can deliver it with the new software systems and the what is called as the dialyzer stress test software, which is available in most of the modern machines. So the filtration fraction ceases to worry us, because as the filtration fraction, as the transmembrane pressure increases, the machine will decrease the flow rate automatically. It may be well applicable to SLED.
I'm not telling about. I'm not at all concerned about the filter here. I know about this, what you are telling, but what I'm telling you, with this level of filtration fraction, what about the antibiotic doses that we have given to the patient?
Yeah, no, because
you are going to that huge amount of ultra filtration you're doing.
Yeah, so Ranajit, these were 4-hour sessions. These were MHD patients, so just a 4-hour session.
A lot of amino acids, lot of proteins we will lose. We don't know in that really protein. I'm not convinced at all.
Yeah, there are unanswered questions.
The Eshol trial also has shown that. That has also shown that the high volume filtration post dilution is effective.
Yeah.
Time will only. Well, thank you.
Thank you, Dr. Lobo. Thank you, Dr. Ranajit. Anything from other panelists, or we would be concluding our session? It's almost 3-hour long session. We started at 7:05 and it's 10:05 or 10:10 in India. So anything from the panelist? So Thank you, everyone. And as we draw to a close on this enlightening session on the third Nephrocritical Care Global Update, I would like to extend my heartfelt thanks to all the esteemed faculties, speakers, chairpersons, the members of the Nephrocritical Care Society, delegates for their invaluable contribution. Today's discussion definitely enriched our understanding, and also that would pave the way for the future innovation in nephrocritical care. And let's carry forward these messages, knowledge, and the insights shared by our faculty, speakers, as well as the discussion held by different members to our respective fields, continuing to make a significant change impact on our patient outcome. Thank you, all of you. Let's be in touch, and let's hope for the better care of our patients. And we would be coming up with the similar type of academic activities in the next April month would be the 4th Global Nephrocritical Care Update, and we would be intimating the dates with the agenda very soon. Thank you, all of you. Please take care. Yeah.
Thank you. Thank you.
Thank you. Good night, Tapas. Well done.
Good night. Thank you, sir.
Well
Thank
done.
you very much.